Assalamu alaikum, it's me Dr. Naseem Shirzad, and today I am going to discuss with you all the prostate biopsy and their indication, contraindication, and complication. In our whole presentation, we will be talking much more on the transrectal biopsy, not on perineal biopsy. So, what are the indications for performing a transrectal ultrasound guided biopsy or prostate biopsy? If the patient is having abnormal DRE or in elevated PSA, or if the patient previous BSA is showing multifocal prostatic intraepithelial neoplasia, or if the patient previous biopsy is negative but the patient is having rise PSA or abnormal DRE, or you want to put a patient on active surveillance and that is a low risk patient, so we performing for that scenario. Now, what are the various complications of the prostate biopsy? So, the various complications of the prostate biopsy include it can cause hematospermia, it can cause hematuria, it can cause acute urinary retention, and it can cause recurrent UTI, it can cause prostatitis. So, it causes the commonest complication is hematospermia, that is 40%. Next is hematuria, that is 20%. It can cause rectal bleeding, it can cause infection, prostatitis, UTI, sepsis, and urinary tract infection. So these are the various complications of transrectal biopsy. So what are the approaches for prostatic biopsy? We can go either with transperineal biopsy, either with transrectal. All the time, according to guidelines, transperineal biopsy should be on top, and they should be your first choice because there is a low risk of infection. That's why it's our first choice. But we in our institute performing transrectal biopsy, and the preparation of the patient for transrectal biopsy is that you should to have in your hand the PT, PTT, INR. Better to have a rectal swab or stool CS to give the patient antibiotic accordingly. Better to give the patient stool softener. Better to consult the patient and take informed consent. And how to take informed consent? Explain him the risk of sepsis, the risk of bleeding, urinary retention, and pain. So better to explain them all these patients. Give antibiotic according to stool CS. If there is no stool CS, then you can go for augmented prophylaxis in the form of fluoroquinolone, iodine, iodine. Coming to the contraindication of transrectal biopsy. Transrectal biopsy in which you better to switch into perineal include if the patient is having painful anal condition, if the patient is having anal spasm, or if the patient is having post APR surgery. And what are the contraindication, oral contraindication for trus biopsy? That include if the patient is having uncorrected coagulopathy, if the patient is having UTI, or the patient is having prostatitis, or if the patient is having painful anal condition. Now, which ultrasound probe should be used? That should be 7.5 megahertz transrectal probe, and the needle for biopsy should be 18 gauge true cut biopsy. And how to give local anesthesia? We are giving local anesthesia ultrasounded guided, and we use 10 ml of 2% lignocaine solution, and we will be using a long spinal needle that is 22 gauge and that is 2 centimeter long, while the probe which we are using for taking the biopsy, that is called the true cut biopsy, that is 18 gauge. So for anesthesia we are using 22 gauge needle, that is spinal needle, and that is having size of 2 centimeter, while for taking the biopsy we are using 18 gauge true cut biopsy. Now the question, what type of biopsy and how many core we will take? We will take 12 core trus biopsy, that is the gold standard. The sample should be as lateral and posterior as possible. Additional core should only be obtained if there is a suspected area in DRE, but the minimum is 12. There is no need to take further. And what is saturation biopsy? The saturation biopsy means to take at least 22 core trus biopsy, 33 to 44% chances of getting positive CA prostate and saturation, and the best way to obtain saturation biopsy is transperineal route. Now coming to the trus ultrasound, transrectal ultrasound. So how CA prostate is looking on trus ultrasound? So it is hypoechoic, and 57% of malignancy are hypoechoic, 40% are isoechoic, and 1 to 3% are hyperechoic. And the differential diagnosis of the hypoechoic lesion on truss ultrasound can be granulomatous prostatitis, lymphoma, prostatic infarct, or BPH nodule. What are the other indications for transrectal ultrasound? We can use transrectal ultrasound for prostatic cyst, for Mullerian duct cyst, for seminal vesicle cyst, and for ejaculatory duct cyst. And it also important to send all the biopsy codes in separate jars. And why we are sending and submitting that biopsy in separate jars? The reason is that in atypical cases, if you want to repeat the biopsy, you can target that previous known location, and more specific location can help us in nerve preserving protocol. And if you want to give a better brachy or cryotherapy, so this can help you in future in this. And a repeated biopsy should be performed within 6 months. Usually we are performing in 3 to 4 months. And the various approach we have already discussed: transperineal, transrectal, finger guided, ultrasound guided, and fusion biopsies. And what you should expect from a histopathologist: you should expect from her the Gleason, the primary and secondary, the total number of core that are positive, and the percentage of each core that are positive. You should to ask from the histopathologist to tell you about the Gleason, primary and secondary, the total number of the core that are positive, and the percentage of core that each percentage that are positive. So it's also important. And what are the Gleason score? Gleason score is actually a grading system to grade the glandular architecture in prostatic gland as seen under low power microscopy. And how much power is used for Gleason score? That is low power, 10 power. And the various glanding score and the pattern which we are seeing in the microscope, that are 5 patterns. Pattern 1, that is normal looking cells, while in pattern 2 there is amplifying, that the stoma size increased, while in 3 there is infiltrative pattern, while in 4 there is any plastic clumps, while in 5 there is all the cells are upon just like a sheet of cells.